Welcome to the deep dive.
Great to be here.
Today we're looking into a really complex medical case. It's fascinating because it brings together rheumatology, pulmonology, and even oncology.
Yeah, it's a stark reminder of how sometimes the immune system can just go haywire.
Yeah.
And in doing so, it can actually flag something much more serious happening underneath.
Exactly. We're diving into the case file of a 42-year-old patient, Sakshi.
And for you listening, our goal here is to piece together how seemingly separate problems, muscle weakness, skin rashes, lung issues, all connected. We're looking for those critical clues in Sakshi's file.
Those moments where the symptoms start pointing to one much bigger picture.
Precisely. How did the doctors get from these initial sort of vague complaints to this really complex diagnosis involving dermatomyositis, severe lung disease, and even cancer?
Okay, let's start at the beginning, the initial presentation. Sakshi first sought help after about 6 months of worsening muscle weakness. And this wasn't just feeling tired. The file stresses it was proximal weakness. Can you unpack what that means and why it's such a key detail?
Sure. Proximal means the muscles closer to the trunk of the body. So we're talking hips, thighs, shoulders, upper arms.
Okay.
She found it increasingly difficult to do things like stand up from a chair, climb stairs. Even simple things like combing her hair became hard work.
I see.
And that pattern is a big red flag in rheumatology. General fatigue doesn't usually stop you from lifting your arms or getting out of a seat in quite the same way.
Right.
When these large core muscle groups start failing symmetrically like that, you immediately think of inflammation directly attacking the muscle tissue. It's not just tiredness, it's muscle failure.
So if it were just the weakness, maybe other things could be considered, like, I don't know, neurological issues. But what really pushed this towards dermatomyositis specifically?
The skin. Absolutely the skin. That's the dermato part of dermatomyositis.
Okay.
Sakshi had developed these painful rashes over the previous 5 months, mainly on her face and hands. And these weren't just any old rashes. They were very specific, almost like signposts for the diagnosis.
These are the classic visual markers you read about, right?
Exactly. You've got the heliotrope rash. That's a purplish sort of lilac discoloration on the upper eyelids. Often comes with some puffiness around the eyes, too.
Okay, heliotrope rash.
See that? Especially with the proximal muscle weakness, dermatomyositis jumps right to the top of the list.
And on the hands?
Gatron's papules. These are really distinctive. They're raised kind of scaly, reddish, or purplish bumps right over the knuckles, the MCP joints, and sometimes the next joints down, the PIP joints.
So, very specific locations.
Very specific. Other conditions cause rashes, sure, but not usually these rashes in these places. There were also mentions of photosensitivity, the Schall sign and V sign, meaning rashes on her upper back and chest in sun-exposed areas.
So the skin was practically screaming dermatomyositis. But the problem didn't stop there, did it? The case file shows things got much worse systemically.
No, it didn't stop there, and that's where it gets really dangerous. Over 3 months, she developed worsening shortness of breath, especially when she exerted herself, plus a persistent dry cough.
And her oxygen levels.
Worryingly low. The exam showed her SpO2, her oxygen saturation, was only 90% on room air. You or I should be, 95% or higher. 90% means her lungs were already struggling significantly.
That sounds serious. And then came the swallowing problems.
Yes, dysphagia. Difficulty swallowing both solids and liquids.
Hey.
It was so severe she experienced nasal regurgitation, food or liquid coming back up through the nose.
Wow.
That tells you the muscle weakness wasn't just in her limbs, it was affecting the muscles in her throat, her pharynx, and esophagus. That puts her at a huge risk of aspiration pneumonia.
Okay, so weakness, skin rash, difficulty breathing, difficulty swallowing.
And add to that severe fatigue and a really significant unintentional weight loss, 7 kilograms, about 15 pounds, in just 6 months. You're looking at a body under immense stress, failing on multiple fronts.
Let's move to the investigations then. How did the lab work confirm what was suspected? The muscle enzyme levels must have been off the charts.
Oh, absolutely staggering. Creatine kinase, or CK, is the main enzyme that leaks out of damaged muscle. A normal level is maybe under 200 units per liter.
And hers?
Hers was 2,800.
Wow, 14, 15 times normal.
Exactly. Massive muscle breakdown. Other markers like LDH and aldolase were also elevated, backing up that picture of extensive tissue damage. And she was anemic too. Hemoglobin down to 9.8.
So the labs confirmed the muscle destruction. What about the immunological tests? That's where you really nail down the specific autoimmune cause, right?
Precisely. The first step, the ANA anti-nuclear antibody, was positive. That just signals autoimmunity is present, but it's not specific.
Okay.
But then they looked for the myositis-specific antibodies, and she was positive for anti-My2.
Anti-My2, and that's considered a classic marker for
Classic dermatomyositis.
Mm.
It correlates very strongly with those skin findings we talked about, like the Gottron's papules. Finding anti-My2 really solidifies the DM diagnosis.
But there was another antibody mentioned, anti-Jo1, which was weakly positive. What's the deal with that? Does having both mean something?
That's a really crucial piece of the puzzle. Anti-Jo1 is the most common antibody seen in something called antisynthetase syndrome. While anti-My2 points strongly to the skin and muscle aspects of classic DM, anti-Jo1 is very strongly associated with interstitial lung disease, the ILD.
Ah. So that positive anti-Jo1, even weakly positive, immediately explained why her lungs were involved. It gave a direct link.
Exactly. It provided the immunologic reason for her shortness of breath and low oxygen levels. It flagged the lung complication right away.
Okay, so let's follow that lung thread. The exam found crackles in her lungs. How did the imaging confirm the ILD?
They did a high-resolution CT scan of her chest, an HRCT, and it showed clear signs of interstitial lung disease.
What kind specifically?
The pattern was described as NSIP, non-specific interstitial pneumonia. Basically, it means inflammation and some early scarring spread throughout the lung tissue. While maybe not as rapidly destructive as some other ILD patterns, it was clearly significant enough to impair her breathing badly.
Got it. So the labs, the antibodies, the HRCT, they all pointed towards dermatomyositis with this serious lung complication.
And they also did an EMG, electromyography, which showed myopathic changes, electrical signals consistent with muscle disease, not nerve problems.
And the muscle biopsy, the final piece. The muscle biopsy clinched it. It showed that characteristic feature of DM parafascicular atrophy. That means the muscle fibers right at the edges of the muscle bundles were inflamed and shrinking. It's the microscopic signature. So they could rule out differentials like polymyositis, which doesn't have the rash, or lupus, which usually doesn't cause such extreme CK levels.
Exactly. The combination of the specific rash, the incredibly high CK, the anti-My2 antibody, and the biopsy findings made dermatomyositis the clear diagnosis. The anti-Jo1 explained the ILD overlap.
Okay, this is where the story takes another really significant turn. We've established the complex autoimmune disease, but dermatomyositis, particularly when it starts later in life, has this known sinister association.
Yes, the perineoplastic link.
Can you explain what a perineoplastic syndrome actually is? How can an autoimmune disease be caused by cancer?
It's a fascinating and frankly scary phenomenon. Essentially, the cancer, wherever it is in the body, might produce certain proteins or antigens.
Okay.
The immune system recognizes these cancer antigens as foreign and mounts an attack. The problem is sometimes those cancer antigens look very similar, molecularly similar to proteins naturally found in the patient's own healthy tissues, like skin or muscle.
Ah, so it's like mistaken identity.
Exactly. The immune system, in trying to fight the cancer, accidentally starts attacking the patient's own body. You can't tell the difference between the cancer protein and the normal tissue protein. It's cross-reactivity.
And in dermatomyositis, that cross-reactivity targets the skin and muscle.
Precisely.
Yeah.
And certain features make you suspect this perineoplastic link much more strongly. Things like older age at onset, severe disease, difficulty swallowing like Sakshi had, and definitely the presence of ILD.
So for Sakshi, with all those features, screening for an underlying cancer wasn't just a good idea, it was mandatory.
Absolutely critical. The DM symptoms in this context could very well be the first sign of a hidden malignancy somewhere else. The autoimmune disease is the messenger.
And in Sakshi's case, the screening found something. This is the crucial link, right?
It is. The CT scan of her abdomen and pelvis revealed an ovarian mass.
An ovarian mass.
Yes, and it looked highly suspicious for cancer, for carcinoma. This suspicion was then strengthened by blood tests, showing an elevated CA-125 level, which is a tumor marker often associated with ovarian cancer.
So there it was, the underlying cause.
There it was. The dermatomyositis wasn't just an autoimmune disease happening alongside cancer. It was very likely triggered by the ovarian cancer. It was a perineoplastic manifestation.
Let's just synthesize this final diagnosis then. We're looking at dermatomyositis complicated by quite a list.
It's a long list. Severe proximal myopathy, the classic skin signs heliotrope rash, Gottron's papules interstitial lung disease with that NSIP pattern, severe dysphagia.
Yeah, the underlying driver, ovarian carcinoma.
Exactly. The case file mentioned this involved 8 distinct domains needing management. Think about that. 8 different systems or aspects of her health failing or needing active treatment all at once.
Can you break down those domains? What makes managing this so incredibly challenging? Okay, so you have 1. The skin, mucocutaneous, managing the painful photosensitive rashes. 2. The muscles, musculoskeletal, dealing with the profound weakness, needing rehab. 3. The lungs, respiratory, managing the life-threatening ILD and low oxygen. 4. Swallowing, gastrointestinal, preventing aspiration, ensuring nutrition despite dysphagia. 5. The immune system, immunological, trying to calm down the autoimmune attack itself. 6. Blood, hematological, addressing the anemia. 7. Overall health, constitutional, tackling the severe fatigue and weight loss. 8. And of course, the cancer, oncological, treating the underlying ovarian malignancy. It's mind-boggling, trying to treat all of that simultaneously.
It requires a huge team effort: rheumatology, pulmonology, oncology, gastroenterology, physical therapy, nutrition, and the treatments can conflict, right? You need strong immunosuppressants to control the DM and ILD.
But you're giving those to someone who also has active cancer, potentially weakening their ability to fight it.
That's the tightrope walk. It's an incredibly difficult balance.
So, given this immense complexity, what did the management plan look like? What were the priorities?
Immediate priorities were to control the autoimmune firestorm. That means high-dose corticosteroids, often given intravenously at first, to quickly reduce inflammation.
Okay, steroids first.
Then you need longer-term immunosuppressants to allow for tapering the steroids and maintaining controlled drugs like methotrexate or azathioprine are common choices for the muscle and skin disease.
And for the lungs, the ILD. Does that need specific treatment beyond general immunosuppression?
Often, yes, especially if it's severe or progressive. Drugs like mycophenolate mofetil are frequently used as they seem particularly effective for lung involvement in myositis. Or if there's evidence of fibrosis, scarring, then antifibrotic drugs like nitadenib might be considered.
And then there's the elephant in the room, the cancer itself.
Absolutely paramount. An urgent referral to oncology is needed for staging and treatment of the ovarian carcinoma. Surgery, chemotherapy, whatever is indicated.
Does treating the cancer help the dermatomyositis?
Often, yes. If you can successfully treat or remove the underlying cancer, the paraneoplastic autoimmune symptoms can sometimes improve dramatically, even resolve. The trigger is gone.
That makes sense. Beyond these major treatments, there's also a lot of supportive care involved, isn't there?
Oh, definitely. It's crucial. Things like specialized swallowing therapy and maybe even temporary feeding support to manage the dysphagia and prevent aspiration. Strict sun protection is vital because sunlight worsens the rashes.
Right.
And because she's on high-dose long-term steroids, you absolutely need to give calcium and vitamin D supplements to protect her bones from steroid-induced osteoporosis. Plus, ongoing physical therapy to rebuild strength. It's comprehensive.
It really illustrates the systemic nature of this condition.
It really does. I think the main takeaway from digging into this case is that dermatomyositis isn't just a skin and muscle problem. It can be, but particularly in cases like Sakshi's, it's a systemic warning sign.
A signal from the immune system.
Yeah, sometimes it's the body's first and only way of letting us know there's a serious underlying issue, like cancer, developing silently. Those specific skin signs turned out to be clues to a life-threatening malignancy.
It's quite profound. Which brings us to a final thought for you, the listener. When you consider Sakshi's journey, how symptoms like a rash, some muscle weakness, maybe initially dismissed as less serious things, were actually the first flags for ovarian cancer and severe lung disease. How did that change how we might think about more common complaints like generalized fatigue or other unexplained symptoms?
This case really challenges us, doesn't it? To remember that sometimes the most mundane-seeming issues, when viewed in the right context, with attention to specific details like where the rash is or which muscles are weak, can be the key to uncovering a much larger multi-system storm brewing beneath the surface.